All right, good morning, everybody. Thank you all for joining us once again for after two very busy and very productive days. For the first part of this morning, we are going to talk a little bit about the imminent launch of the Accelerate project. So I'm going to give a little bit of an overview of the structure of the study, an update on where we are on all the components of this moving towards launch. But then I want to spend some time talking about the types of patients we want to prioritize for inclusion and enrollment in Accelerate, particularly from our discussions yesterday about historical comparators and refractory patients and the kinds of patients we feel haven't been included in such studies going forward. As this is our that goals that I just gave. So the full name of the study is Accelerating Therapies for Refractory SJIA Patients. This is a multi-site study funded by the Systemic JIA Foundation through their partnership with Chan Zuckerberg, as well as their own fundraising efforts. Its objective is to enroll a cohort of patients, initially funded for 50, who, as we wrote this last year, had said both typical course SJIA and refractory course. But that's one of the things I want to circle back to at the end is about that enrollment. And those refractory courses include those with recurrent or this quote persistent partial MAS, chronic lung disease, chronic liver dysfunction, and chronic refractory arthritis. To obtain detailed clinical information, as well as high quality biosamples from that initial cohort of patients, and then to use that to generate a multi-omics data set, including whole genome data, proteomics, single cell RNA sequencing, whole blood, transcriptional profiling, multi-parameter flow cytometry, to be available initially to members of this Accelerate Consortium, but then quickly thereafter to be publicly available to be a resource for further research into this area. So this is the Accelerate Consortium. It will initially be these 9 sites that originally expressed interest in being a part of this. Emory is going to be on hold because they don't have the bandwidth to launch this at this time. So the initial launch is likely going to be these 8 sites here. As you can see, we run into a wall at Houston and don't go further west. So I think one of the things we do want to do is get some sites from the Western US involved in this at some point. But this is the network as it stands. So this is sort of the overview of the study and what were the procedures that will happen for patients enrolled in Accelerate. So there will be a screening and baseline visit, and then annual follow-up visits at 12 months and 24 months, and then the ability to do sort of a flare or ESI visit when either a new complication has been diagnosed or there's a significant disease flare, so that we can get further clinical information as well as biosamples at that time to try to understand what's happened. You can see here at sort of all of these visits, getting information on their baseline, but then their interim history, what's been happening with their medications, doing a careful physical examination, getting a number of patient-reported outcomes, and then collecting biosamples. So DNA at baseline, and then at all of these visits, being able to get whole blood RNA, plasma, serum, PBMCs, urine. We have the ability through this protocol to get stool. We have the ability to get leftovers from other procedures such as BAL fluid from a lavage, lung tissue from a lung biopsy, bone marrow aspirate from any bone marrow biopsies through the protocol. At baseline, the protocol also allows us to then consent the parents as healthy controls, obtain DNA from the parents so that we can do trio West. And then we also want to have sort of harmoniously collected control samples. And through our prior SJIA family days at Cincinnati, we've really been able to leverage the power of siblings who, will give us, again, the hard part is when we've tried to get quote unquote healthy controls locally at Cincinnati, is we find healthy kids don't get their blood drawn very much. If you are getting them at, the lab, they're there for some reason. They're there for medication monitoring for things that we don't know how that's going to affect things. They skew older. They don't always match the demographics of this population, whereas siblings, I think, are a very good source of that. They're often very motivated to do a little small thing to help out their sibling. For families, it's nice, you're there, one child has to get the blood draw, the other child, it seems okay for them to also get the blood draw. So so we're targeting then siblings, and to be able to get that at a baseline visit also, because then we will have control samples that are collected at all of these sites across the network. Won't just be from one site, to try to minimize the sort of the batch effects and other variability that comes with control samples. As I said, the biosamples, this is sort of based off of the Canna biosample kit, which is what we've moved to using in Cincinnati. It's getting CPT tubes to be able to get PBMCs, getting serum tubes, DNA, often EDTA tube, Tempest whole blood RNA. As I said, we can get saliva from parents for DNA, we can get urine, and then the ability to get these leftover tissue samples as well from clinically indicated procedures. The lab manual for this is being finalized and should then be able to be going out to the sites for review and any comment before the end of this month. So where are things with the study? So the REDCap database, that build is in progress. We've just heard from it's being built by the CCTST here at Cincinnati, that they anticipate it to be ready for some beta testing next week. Sanjeev, who some of you know in our team here, is going to be managing the database, as well as doing trainings for the sites on how to use that and checking for data completeness, et cetera, as we get going. So he hopefully will be beta testing this next week. And then hopefully being able to have it be launched very, very soon. The PedsQL, having that be contracted for use here, that is just waiting the final approval, and then that will be ready to go. And once those two things are complete, we anticipate being able to enroll, certainly here at Cincinnati, as soon as those are ready to go. As far as the other sites, as I said, the laboratory manual is being finalized. We will then start putting together the sample collection kits and other supplies. Most of those are going to be provided by us as the centralized bio repository for this and sent to the sites. So those will be ready to go. Where I think many of the sites are right now is in the various stages of the contracting process. I believe it's started at all sites. Some sites are waiting for Cincinnati. Some of them we are getting, working on finalizing the contracting numbers with the various sites. All of you should be in contact with Alex Herman, who's our business manager, who's been leading this contracting process. And so I would encourage you, for any questions about where we are and the current status, to reach out to Alex. If you've lost his email, the Cincinnati emails are very easy to hack. They're just first name dot last name at CCHMC, or you can email me and I can make sure that he gets your questions addressed. Any questions about sort of some of these logistics of where we are with the study before we kind of move on to talking about the kinds of patients that we want to target for enrollment on this?
Grant, could you cover the REDCap again? Is that going to be done from our own sites, or how's that working?
Yes, yeah. So that will be a REDCap cloud, which will then be able to have every site be able to enter the data from their patients into that centralized database. Everyone then will be able to have access to all of the data to be able to run reports on that on the entire cohort. And then we'll also be able to then track the biosamples that we have available for those patients also through the database. We'll be able to know what we have from what time points and which patients.
So, Grant, one question I would like to raise is that sort of this study, this network is aimed at getting right samples from patients at the time of a flare, and sort of it's at the moment it's sort of a prospective study, if you wish. Considering all the discussion that we had yesterday about sort of the need for historic controls, is it possible to use the same network and add a retrospective component with collecting the clinical data on patients with, let's say, with macrophage activation syndrome? And again, the clinical research forms that we have at the moment, they capture exposure to drugs, they capture pretty much all the clinical features that we discussed yesterday. So the moment, again, it's set up as something that is prospective, and again, the main goal is to get those flare samples. I remember at the beginning of this project, somebody actually wanted to call it not accelerate, but rather flare net. Again, to stress the point that we are.
I like that. No one told me that. I would have voted for that.
Yeah, but anyway, the point is that sort of at the moment is but can we use? Would it be possible to use the same network to address some of the issues that came up yesterday during the discussions with the FDA?
Potentially. I mean, I think the question is, how much of like the database infrastructure could just be cloned to get that same data, but in a retrospective fashion. Probably a lot of it could, which would make the building of the database and very easy. The question is whether that we probably would need a separate IRB is the problem, because it would be a retrospective study versus a prospective study. But that I would have to think about a little bit more. But certainly the connections that we're making amongst these sites through putting this together would lend itself to being able to do retrospective studies also.
So how does this overlap with the other lung disease study then? Are the same patients going to be enrolled?
They could potentially. The sort of the vision that the foundation has had is sort of this. We sort of thinking of it as sort of like a Russian doll or sort of nested circles, which at the broadest thing is patient directed, information that patients, studies that the foundation can do, patients, families providing their own information. The next one being things that can be collected through the entire Canna network, for example, of 70 plus sites, like the registry and like the LD core within that. And then a smaller number of studies with this Accelerate network where we're able to get even more detailed information, more complex biosamples than can be collected through the Canna registry. Again, so all of these are going to be PBMCs are going to be processed locally and frozen so that they can be used for sequencing, being able to get other biosamples like bone marrow, lung, liver biopsies, et cetera. So the question is whether certainly some of the same patients would be eligible for registry and eligible for this. And so that gets to some of these questions about who are the patients that we would want to target for enrollment in this. Ones that, that are not being captured by other longitudinal studies, but also, would we want to get sort of any patient at any time who has this refractory disease course, or would we want to get them enrolled at either the time of a clinical disease flare or at the sort of diagnosis of when they're refractory, right? So when they've had the recurrent MAS episode, where they've been found to have lung disease, where they've now failed both IL-1 and IL-6, for example. And so I think that's one of the things that we should think about, because we don't have at this point, we don't have the funds to have hundreds of patients in this. We have a budget for about 50 or so patients. So we want to make sure we're getting the most valuable patients that we can into this.
Thank you.
So I'm interested in people's thoughts on that, and on this thought of, whether we would also want to have within the same ones, quote unquote, typical course SJAA or new onset patients, to have within this collection patients who behave normally, or whether we feel that some of the data we heard about yesterday, including Frost, including the Utrecht cohort, including others, has that well covered. And we feel like that instead we need to focus on those that aren't currently being studied by those types of projects.
So, Grant, can you hear me?
Yeah.
Take it with a grain of salt. I'm just a parent, but I've been around for a long time, and to me, I'm not 100% sure I agree with what Alexei was saying about trying to use this also to collect like some of the information we were talking about yesterday with like historical controls and things like that, because from what I've seen over the last 20 years, we try to do everything into one thing, right? And we make it so darn complex that we make it too hard to do what we originally set out to do. So I think if, we should be a little bit more focused. That's just my opinion and something that I have seen over the years.
May I jump in? I think Vincent has a point.
Please.
And I hate to say, but sometimes we make things very complicated, and we have to keep it simple. So this is an excellent thing. This accelerated studies is excellent because it allows collection of samples. On the other hand, we could use the same networks and the same centers, but not the same database and the same project to collect retrospective. I think the retrospective data are Grant. Keep it simple. I love that. Yeah. So maybe we should actually do two things. They're going to be the same centers, but the retrospective collection that will allow us to collect natural history data is by far more simple and less granular than the amount of data that you want to collect here. This is my guess.
Right. I think that, the patients that you might want to be, the patients and the sites at which you want to enroll, the interventional part of the study will come from these places, I would imagine, and from this cohort. So
Right. Because this could then lead itself to a cohort that could be, an adaptive trial design or something. But I think we need to understand, again, this will allow us to understand the biology of this and these complications.
I just wanted to quickly add that I really like the way that Grant described the whole, kind of the concentric circles. And this was definitely meant to be able to capture the kind of more detailed data that it's hard to do in a larger network. And I think that we should definitely, and the hope is also to work with the European centers, a few of them. So in that sense, also, it'll be different. We still need to, and that's why I've invited, our European colleagues today to join us so that we can stay coordinated in terms of how we do things, even while we get the paperwork to lined up. And for the natural history study, I think we definitely need to see what are the requirements, what are the numbers needed, and then figure out the best way to do that. Maybe we do use the, same, once you set up a structure, it's so much work. You want to use those structures again. But otherwise, we should go by the need.
So can we talk a little bit about this question of whether we want to have typical course / new onset patients enrolled, one or so a site as a comparator, or whether we feel that is not where the money is going to be at this project, and we feel we have enough understanding of that to not do that. And I'm interested to hear from both the rheumatologists and the scientists as well as the patients.
Grant, can you comment on what would be the differentiating factors for how would you describe refractory SJA in order to differentiate the two groups?
The group of typical course, you mean?
No, I'm interested more in about what would put someone in the refractory category so we know we can leave the typical course behind. So typical courses, they respond first time to anakinra and then we're done. And then
Correct.
everyone else is
So-
refractory? You see what I mean?
Yes. So I'm going to stop sharing while I try to pull up. So at the meeting that we had in 2019, before the world blew up, we came up with some proposed definitions of what that would look like. And I'm going to see if I can find those while we're talking.
I think, Bas, do you have that handy? You sent that out recently. Let me try to find those.
Hold on, I've got it. I just found the paper.
I think Grant has that.
Yep, I just found the paper here. I'm just trying to find that table so that I can pull it up and share it.
I think it was failed IL-1 or IL-6 inhibitors. 2 or more
Yeah, here we go.
results.
Yep.
Lung disease, relapsing. And fourth one. It was 4 or 3. I forgot.
Here, hold on, I've got it.
It was 4.
I found it. Can everyone see that? Failure to respond to IL-1 and IL-6 blocking biologics, which we define as inability to resolve features or being steroid dependent, or having 2 or more episodes of MAS in a 2-year period, or development of lung disease.
I think we should add the liver disease as well, Grom. Yeah.
But I think that's in there. We note the sort of liver failure to resolve liver dysfunction with IL-1 and IL-6. We could have a sort of a separate, excuse me, do you think we need a separate definition of liver dysfunction, or do you feel that failure to respond?
No, I think it's a liver dysfunction. It's too broad. Remember the last combined conference we had in Cincinnati, and it was at least 5 different type of pathologies, if you could see here, right?
Mm-hmm.
So
how would you
I
define
think
the phenotype we're looking for?
Well, really, it was subclinical MAS with predominantly liver involvement. That's a sort of group that we can we.
Mm-hmm.
Why don't we just say that? Say just that. Recurrent MAS with predominantly liver involvement.
And I think we also did come up with a definition of what we called persistent partial MAS, which we didn't
should
all
be the
love.
same publication, I think. Right?
Exactly. Let me see if I can find that also here.
Does seem they'd be captured in that definition.
I think the issue of definition of these refractory courses is really critical because not only we today should agree on this, but also all physicians that see refractory cases that are not present here should agree on this, should be broadly supported. And I think we said that for now, this professional criteria are a perfect starting point, but we need a consensus day or maybe even 2 to get broadly supported criteria.
This is this proposal for persistent partial MAS, patient with active SJA, persistent inflammation, worsening or persistent abnormalities for at least 6 weeks, including liver abnormalities, cytopenias, coagulopathy, very elevated IL-18, modestly elevated CXCL9, as sort of this picture of what is subclinical MAS, or what we called persistent partial MAS, or what Dr. Brunner called smoldering MAS.
She was calling it schmoldering MAS.
Smoldering. I was being kind to my
Be
European
careful.
colleagues.
I don't think I just logged on. That's
Yes.
a term I don't like, actually.
Yes,
I think there needs to be a medical term.
partial. Yeah, I
It
like
sounds
this.
a little bit, not
This
appropriate.
persistent partial was, I think we liked that because it gets the fact that it's persistent, and then
What
it's
about
not.
subclinical?
Well, again, we kicked that around, but I think people didn't really know how we define that, and so we spent a lot of time on this at that 2019 meeting, and the best we could come up with was persistent partial. Although that had a majority vote, but it didn't have 75% of us agreeing to it, if I recall correctly. But that captures these sort of persistent liver abnormalities. So that group of persistent partial MAS as also sort of one of these refractory disease phenotypes.
And it does seem, quite easy to be able to define people who have typical course, and we would not put them in, in the set of refractory or persistent partial MAS. It would take a lot to put those in there. So I think it'd be quite easy to differentiate typical course if we use any of those criteria that we came up with back then. So as long as we have a clear defining line, I would vote for not including the typical course, only because we do have the CARA database and, Boss's work. And you only accounted for 50 patients total.
That's the thing. If we could get 200, if we had the ability to get every patient, that would be one thing.
Yeah.
I also think that from a pragmatic perspective, I think if you orient the study towards capturing also the new onset, then you're going to get them right at the beginning. Whereas the refractory, you don't really know if someone is refractory or not. So I think what might be interesting would be to actually, when you have the first sign that someone is refractory, then you start enrolling them. And then some of them might get, controlled by themselves. So don't get them when when you really see the long-term refractory disease. Start like the first sign they fail something and you say, okay, let's enroll this patient.
Yeah. That's a great question that I want to then talk a little bit more about. Before that, does anyone want to make a case that we should include new onset and presumably typical course SJA in this cohort before we kind of put that to bed? Okay, I'm not hearing anyone jumping up and down.
I mean, they'll be easier to enroll, and they kind of serve as a control group, but if you're going to limit it to 50 patients, they'll suck that up right away.
Exactly. And we have, between what, the Utrecht cohort, between our Cincinnati cohort, between Frost, we have a lot of biosamples from that group. And if we want to say, that's interesting, we found this proteomic pattern, between the folks on this call, we can tomorrow give you 30 serum samples from typical course SJIA, and we can look at those, right? We don't need those. We need this group, especially paired with this really detailed clinical information. Okay, so then what Rashmi just mentioned, which I actually really like, is trying to enroll these patients at sort of the time when they are sort of recognized as being a refractory course, or sort of a flare of that or a new complication. So, at the time where they've now, they didn't respond to, IL-1, again, going back to Boss's flow chart, right? They didn't respond to anakinra, we increased the dose, they still aren't responding. Now they've been put on, steroids or tocilizumab, and now they're still not responding. So now we have them that they've not fully responded to the two classes of biologics, or they've now had a recurrent episode of MAS, or now they meet this criteria for this persistent partial MAS, or they're recognized as having lung disease. That would be when we would love to get them enrolled. The question is, do we want to limit to that, or do we really just want to sort of target those, but also get some of these sort of long-standing, challenging patients that we've all been caring for a while and tried a whole bunch of things on?
I think if we do it this way, it will take us a long time to get enough samples. I think we should go for all the refractory as quickly as possible.
Other thoughts from both the patients as well as from the MDs?
These are the kids that need the help now that we need to learn about. The bad is they're incredibly complicated with all the things they've gone through up to this point.
If we assume, Grant, that the refractory arthritis patients are just more severe standard, if I may say so, SJIA patients, I'm afraid, and they are a problem, but they can access the standard trials. They can, they have a number of therapeutical approach there. I'm not saying I'm afraid, but I have a background concern that they should be concentrated on that lump of patients with, subclinical
Yeah, the other phenotypes, the other refractory disease phenotypes.
Yeah.
the persistent partial MAS, recurrent MAS, chronic liver disease, lung disease, exactly.
The one we have been talking yesterday about. So I guess I would rather not include the bullet number 2. It's not a real focus of this. And again, if we were to share samples from Europe, which I think we should, actually, I think we must, let's put it that way, we have to make sure that we get the same database, at least that we can collect the same data and harmonize this. So most probably we are, but just make sure that we are. Okay.
And you're sort of thinking about refractory SGAA does not target that sort of just refractory joint, which, as you said, is maybe just the 90th percentile severity of typical course SGAA.
I mean, it's a feeling, not even an opinion.
Okay.
I don't know what is the thoughts of the other people here.
Yeah.
I'm just thinking aloud as we speak. But certainly making sure that we collect the same samples, which we do because we use the same procedures. Just make sure that we collect the same samples and we collect the same kind of clinical data.
Yeah.
We could always go back retrospectively, but
It might be a slippery slope because if somebody has some arthritis, even if to subdivide this refractory course, but you could stratify.
Yeah.
No, I know, Hermine, but some arthritis is fine. It's the rest of the phenotype that really matters.
Right.
Some of these patients do have arthritis.
Yeah, right. We're not excluding you if you have arthritis, but if it's just refractory arthritis and none of these other complications, never MAS. And that also gets the question that I saw Mariana dropped in the chat, which is an interesting one, which that technically you would say that somebody who failed IL-1, failed IL-6, but their arthritis resolved with some methotrexate would satisfy that definition of refractory SGA, refractory arthritis. And that's not the phenotype we want. Okay.
I mean, getting back.
You yesterday talk about an IL-18 level you would add. Those patients probably wouldn't have a high IL-18.
I think, Hermina, we should be more inclusive here. And in fact, we should confirm that these patients are indeed, all of them are distinguished by high levels of IL-18. So at the inclusion, I would not focus on IL-18, but certainly we will check for those levels and then see whether, in fact, all these 3 groups, all of those patients have high levels of IL-18, or there are exceptions from that rule. So I would not use IL-18 as an inclusion criteria.
Grant, what do you expect? Yeah. It does seem like I'd want to see at least a substantial portion of people earlier in the course. I mean, I certainly just, have cases now of patients who show up with, without arthritis, with inflammation, with an urticarial rash, and I know they're going to be the ones who develop lung disease, right? And I agonize over that. And then, I had one this summer, no matter what I thought about doing, she still developed lung disease.
Yeah.
So I wonder, we've got a substantial, proportion of patients that we're all familiar with who've been in a lot of studies and they should be included, but it does seem like we'd want to capture patients earlier in the course as well. So whether it only includes, at diagnosis or some proportion of those, I'd be interested in that.
And so the question is, do we want to give guidance to the sites of having sort of a limit on the number that are sort of long-standing refractory versus sort of incident refractory? We don't want to be prescriptive, but as you said, we don't want to leave that group out because they're a very important group to study to understand how this refractory SGA phenotype evolves.
I completely agree with Mona there. I mean, in the group as well, some of us parents who've been watching this for a while, we kind of can tell when a patient is heading that way before they know it. And it's you can't say anything, but you can kind of recognize.
Like watching a train wreck.
Yeah, it is exactly. And by the way, we feel that way about the liver phenotype as well now that we've seen several patients, not just the lung phenotype, but the liver phenotype as well. So it would be nice to start capturing them. And I think from what I know, IL-18 does seem to help find them earlier. Like if you see that, if you see it in times of non-MAS, it's still elevated, then I think you start thinking that there's something.
Yeah. But I think that getting those patients at sort of that early recognition of their refractory phenotype will be helpful to answering that hypothesis or addressing that hypothesis of, is that a marker for people who are heading down this road?
No questions. When I see a very high level of IL-18 at disease onset, it makes me very nervous. But I think that patient population should be captured by the Canna registry, right? Grom, you.
Yeah, those at diagnosis that are, have some of those features at diagnosis, that are at the 2-year-old with an urticarial rash and primarily systemic features and a super high IL-18 who's not responding to IL-1. All those red flags. Having those in the Canna registry as early as possible. And we do, within speaking again specifically for lung disease, we have a category of the suspected lung disease, which is it was eligible for that cohort. So you don't have to have, at the time where they're having tachypnea or they're having some clubbing, but they don't yet have anything on their chest imaging, they would be eligible for that cohort. And so we'll be able to get
the other
samples from them
phenotype I think it would be very important to catch is to cover. For whatever reason, recently I have seen a few patients who developed this pruritic rash with eosinophilia at disease onset. And I think, Mona, you were referring to the same phenotype as well. And it's something that I don't remember seeing that often in the past. And that perhaps the phenotype that leads eventually to the lung disease in many patients. So whether through Canna or through this mechanism, that's sort of another very important phenotype that we need to capture.
But that was actually the phenotype I was referring to, Yuki, when I was saying I struggle with whether to enroll them in Canna, right? Because they don't have the classic rash. They may have the fever, appropriately high ferritins, for all intents and purposes.
Right, and it's very interesting.
So I worry I'm missing them in the Canna registry, and maybe I'm not the only one. Is the reason I pointed that out.
Right, and if you biopsy this rash, it's interesting. It's mainly neutrophilic. It's very, very sort of something that you could see in other autoinflammatory diseases. So it's the phenotype that is becoming more frequent, and it needs to be captured. That's for sure. Whether through Canna or through this mechanism, that we need to decide. But it's a very, very important patient population that could give us lots of clues to the understanding of nature of many things.
So, I mean, if but you're hesitant to enroll that patient because they don't fulfill enough of the criteria, or if you're pretty sure that the patient has, this disease, systemic JIA or still whatever, then I would go ahead and enroll them.
Because remember, the Canna registry doesn't require arthritis. It doesn't. If you think this is systemic JIA, you can enroll them. Yeah,
and people are enrolling them, I believe. So we should try to get that message across. Speaking of,
please.
I just wanted to maybe not now, but at some point, after the meeting, we should really try to harmonize the data collection a little bit with the registry. If we're going to think about, using populations of patients, of new onset patients, et cetera, from the registry and from Boss's cohort, potentially, that we want to be able to, collect the same types of information. So we should try to take a look at that. And if we're going to use this as potentially historical or external controls.
Absolutely. All right, so I think that we have some consensus on these 3 questions, that we do not want to enroll just any new onset patients. We really want to get those who satisfy one of these refractory SJIA definitions. We would love to get them at sort of the, when they become or recognized as refractory SJIA, but we're not going to limit to that because we want to get those who've also had a more established refractory course. And that we really don't want to focus as much on the refractory arthritis patients, but really the other phenotypes of recurrent MAS, persistent partial MAS, lung disease, and chronic liver disease. So I think that that I think is super helpful as we think about how we're moving towards launch of this. Any other comments or questions on that? And then I think we can broaden our lens a little bit and think a little bit about this, this retrospective natural history question.
Hi. So if the concern of not enrolling patients at onset would be that we're going to miss the initial information, and I think Dr. Kimura was saying, like, maybe if we enroll everyone either on Dr. Vastert's cohort or on the care cohort, and then you like if you standardize the collection, once the patient becomes refractory, you enroll on this other arm of the study, but you're still going to have the information from the onset based on the other cohort. So if as long as the information is like harmonized, you can actually get the whole picture for everyone. Just the blood sample, I feel like the care cohort doesn't collect for everyone, right, Dr. Kimura?
Correct. So right now, it has the ability to get those, but they're the only active biosample collection right now for systemics is in the lung disease cohort. Although there's interest in expanding that to at least get DNA.
So like so we're sending the a care grant to actually start collecting like blood samples, like with the STARS plan. Should we also include other blood samples for like to see if we can actually start collecting the rest of the blood samples that you would need as a baseline for this study on the STARS grant?
Yeah, it's a great question. We should talk about that. So there's interest from a couple of care investigators, Mariana and Mike Umbrello, as well as Lauren Henderson and some others at Boston, in trying to get certainly DNA from a lot of systemics in the registry. Again, in prioritizing new ones so that we can get those from the beginning and relate, how they're responding to medications to some of these HLA types and other genetic risk alleles that Mike and others have identified. The question is whether it would be valuable to invest the money in trying to get more biosamples beyond just DNA and RNA.
I can pop in, at least Mariana, for the project we're working on, there is a budget.
Yes,
so
that's the issue.
Unfortunately, so I think our plan was maybe to start with DNA. And the great thing about CARA is there's grant mechanisms 2 times a year for people to put in to collect more samples. So, we could do DNA and then another group could put in another grant to do more biosamples.
Yeah. And that also does get whole blood RNA also, which again is not as sexy and sophisticated as PBMCs and things you can do with it. But, I think there's a couple studies now, Virginia Pasquale's original work with the anakinra, some analysis we've done from the canakinumab data, that there are transcriptional signatures you can see in whole blood that relate to treatment responses. So you will get some information from that, although not as rich as if you would have PBMCs.
Grant, do you think it would be feasible for the Accelerate sites, when they diagnose a new SJA patient, to enroll them but not study them? So just freeze the samples. And then if they do become refractory, that 10 or 15% that are going to meet these criteria, then you have it.
We should talk about that. I mean, I think like sort of what Mariana had just said, some of it comes down to money, right? Is that if we want to, that we can do that, it's just, it's a substantial amount that we're paying for site payments for enrollment for each patient, because we want people to really spend the time and get the correct information. We know that it's not always an easy chart review. We want to compensate people for the time to spend a couple hours digging through these charts to get us good data, getting us high quality samples. If we have the resources to do that on more patients, more is always better. But the first phase vision was do more on less. Get really detailed data on a smaller subset of patients. But if we have the ability to broaden that, I think that would be of interest. I see Bryce's hand up.
I just agree with Randy on that point. I think the advantage of collecting the samples on all of the patients is that that's the only way we're going to understand what differentiates those who develop the more severe complications. Mm-hmm. We need the ones that don't to as the comparator group. And that obviously will require more funding, but that's an essential group, I think.
The nice thing is once Accelerate is launched, it gives all of the sites the regulatory infrastructure to be able to do that. It's just, how do we pay for it? Which, is part of it, but the regulatory is already there, right? You'll have all of the kits, we'll have the database, we'll have the IRB approval, we'll have the consents, everything, and we can then do it.
I mean, I guess the other option is we could just store it at our own sites, because we don't need to give you detailed clinical information. I mean, we could, if at some point, like Bryce is saying, you want to compare groups, but if they ultimately become a refractory patient, then we can go back, and the EMR is not going anywhere. So you don't have to pay people to collect a ton of data up front. What you really need to do is just think ahead and save a sample, or whatever you want saved. And it doesn't have to be everything. Maybe it's serum and DNA.
Yeah.
Well, that's not a huge expense. It's could be done, certainly, yeah.
I think we should keep talking about this as we launch. Sorry, who is?
No, just saying. So if you were thinking of doing that, why not just enroll them in the Cara registry? That way you have prospective information on those patients and detailed information, and potentially, we could have a grant mechanism to collect at least, just the Cara sample kit on those patients, and we have it, Yeah.
I think that's something that we can, once we have our first meeting after we get this launched, we should keep this question on our agenda every time, I think, about whether we want to, enroll more patients. And again, we don't have to, as you said, we don't have to collect all the clinical information, all the biosamples, do the full, yes, we're going to get a 2-year, the entire 2-year longitudinal study, but we can't go back in time and get that initial sample and initial data. And even even retrospective data collection, we recall things differently when we are asked to look back a year and say what happened a year ago before all of these things happened, versus getting it prospectively. Sorry, Lauren, I didn't mean to talk over you.
I just want to emphasize, me and Grant created a grant mechanism, Cara, that happens twice a year, where groups can put in proposals to collect biosamples in the network, $50,000. Twice a year, you can put in a grant for that. So, and the next will be in the fall. So you could propose to put in a spin collection and get the same samples that you're getting in Accelerate for new onsets in the Cara network. It has to get approved, and you have to go through a grant approval process, but that is available.
All right, great. Well, this was super, I think, helpful to clarify some of our initial thoughts and then things we need to think about as we get this off the ground. So, Alexei, am I turning over to you to talk a little bit more about this retrospective natural history now?
Well, I think it's probably Fabrizio who has a couple of slides, right?
Excellent.
No, I put together a few slides that I showed yesterday, but I guess the point here is decided what we want to collect, and I think we have received some very important information yesterday. If we want to use the retrospective information as an external control for a clinical trial in this patient, which I think we must use, the point is agree on the minimal database, which is going to be significantly less granular than the ones in the Accelerate study or in any prospective cohort. But as to collect some relevant information. I went back to the paper that you pulled out, Grant. It's your fault. And it was pretty clear that there was one table there in which the participants, forgot the number of the table, but I can pull it out again, in which all of us agreed on a number of variables that could be looked at in patient with that particular phenotype. Do you still have the presentation with you? Because my other just crashed. This table, what's wrong?
Yeah, I think, is it this here, table 3, Fabrizio? These
I can't open my other Acrobat reader. I think Zoom is messing up too much.
Can you see, is it this here or?
Here it is. That's the table. potential parent-reported outcome measures for systemic and lung disease, which I think it's a starting point. So I don't think we have really looked at that in detail. Some of them are not objective. It's very difficult to get them retrospectively, but
yeah, I think retrospectively it will be almost impossible to collect this type of data.
Yeah.
If anything, it's table 3. That's the one that gives us more.
Just 1 second. Increased respiratory rate is collected for hospitalized patients, and respiratory rate is collected. It's available in the chart. We have to find a way to make it objective. So maybe a mean, but the respiratory rate should be collected, and oxygen requirement is being collected. And these are the only one. I agree with you.
Mm-hmm. Yeah, some of these, you know, I remember that this is a very interesting conversation we had at the meeting with our family partners, because it was sort of predicated on this, you know, these quality of life measures. These are these very mobility focused things from the arthritis world, which were great for Polygo, JIA, don't really capture this. And so many of these are these sort of soft things that you know it when you see it, and the families know it because they live it all the time. But how do we capture that in an objective way? And definitely through the retrospective scope, it would be impossible, because they're very filtered through how you remember how things went. But doing it in a prospective way, which can be done, again, can be done through Accelerate. It can be done through the Canna Registry, could get these things, because you can ask them, you know, about these things.
I also have a major point for me on the outcome is CT readings. So most of these patients have done CTs, and we could go back to the CTs of the lung CTs of this patient. The problem is, can we plan for centralized readings of this CT scan? Who is, I mean, Alexei and Grant, probably your radiologists have the highest experience on this?
So what we have done, Fabrizio, there are very few very characteristic features that we pick up in these patients on a high resolution chest CT. You know, pleural thickening, there is a little bit of ground glass passages, some consolidation, so we can actually list those features. We believe there are about 6 or 7 distinct features that could be picked up on a high resolution chest CT imaging, and then we can grade each of those features based on the severity, and then potentially could come up with some kind of a score that needs to be validated. My concern is that sort of what we're having done follow-up high resolution chest CT on a few of my patients, you know, you may have 2 components of the disease, right? You may have active inflammation, and you may have a little bit of fibrosis. And then let's say you get that inflammation under control. Patients clinically is better, doing better. If you look at oxygen requirements, they go down. But if you repeat your high resolution chest CT, you still see changes that do not improve. And that may reflect that sort of fibrotic component, that whatever you do is not going to go away. So the problem with high resolution chest CT is that it does not distinguish active inflammation versus fibrosis. And so we should use high resolution chest CT, but my point is that it may not be sensitive enough to reflect improvement. To me, measures like oxygen requirement, overnight pulse oximetry, 6-minute walk test would be much more informative than
I know, Alexei, but this would not be available retrospectively in most patients. So the only thing that is going to be objective is oxygen requirement. We can certainly try to, you know, to look at the CT scans, but I take your point that fibrosis is not a good thing, and it's difficult to distinguish between active inflammation and fibrosis.
So what Ed Behrens presented the other day, right, is a very good example. The patient was treated with the bispecific monoclonal antibodies, mainly for the lung disease. and there were lots of functional improvements in terms of, again, pulse oximetry and those 6-minute walk test. But the CT scan did not change that much. And again, I think that's sort of exactly what we're seeing.
What I'm trying to understand from you is that I know the CT scan didn't change that much, but can we look specifically and try to differentiate signs of inflammation from, chronic consequences of chronic inflammation, such as fibrosis? Is there any way we can do that? Because this can be done retrospectively at any time if we can come up with something that makes sense. Again, this is not going to be the primary outcome because the primary outcome has to be different. This is just supporting material. We can discuss the primary outcome at length later, but this, I think we needed to have, I think the message yesterday was that we needed a lot of supportive material. Glucocorticoids, total dose of glucocorticoids certainly is relevant. The immunosuppressants and the consequence of long chronic immunosuppressions, it's relevant, but cannot be the primary. The primary has to be a hard outcome, which can be, which has to be very objective. This is their take, and I think we need to think about this and need to discuss about that. This is partly the slide that I showed yesterday. I'm taking a few notes. But you are all free to contribute to the thinking of the variables that we should collect.
Sorry, I wanted to ask if, those who, both parents and doctors who've treated these patients, what labs do you, which are concrete, start, changing as the patient gets better? In my own observation, I think a combination of CRP, ferritin, and platelets are quite telling. I'm curious what others, parents, LFT, CXCL9. CXCL9 is good, but it becomes normal, but you can still have disease. In that sense, IL-18 is better. But what do the doctors see? What do they see as signs of improvement?
Think always this is retrospective, and therefore CXCL9 won't be available, nor IL-18. Let's assume they won't be available, and we can't use those as objective signs of improvement. I added LDH because I feel it's important, and I take ed experience as relevant.
Yeah, the same with us. And then interestingly, again, going back to the patient that Ed presented the other day, remember he mentioned LDH several times.
Yes.
And it was one of the most dramatic outcomes, in fact, laboratory outcomes.
Just to go back, can I make a consideration of these four here? These four, the first three are the ones that are more closely related to MAS. And there are data showing that dynamic changes in these three ones are related to MAS onset and MAS improvement. And the fourth one was not included in the list because there were not enough LDH level in those set of patients that Randy remember very well that were used in the 2016 criteria. So, and there was a lot of discussion around LDH because we all felt it was important, but there was not enough, again, not enough statistical support to include it in the model that allowed the design of those criteria. Randy,
there's a lot of reasons why the LDH may move, but I do think the AST and ALT are pretty fast. And for MAS, they're easy to track. They're often ordered. I really like the LFTs as much as any of those.
I like fibrinogen. I think it changes quickly.
I apologize that I'm constantly jumping in and out because the patient care issues never seem to end here. But can I clarify, is the objective of this, and I apologize, was already stated, to try and have historical controls for a registration-based trial for a new drug? And these would be the outcomes for that?
This is part of the act. outcome. Ed. So the point, do you remember the discussion yesterday on external controls? Were you present?
Yeah, I was in clinic all day yesterday.
Okay. There was a clear message that we need a hard outcome, and there were examples on other disease, obviously, and unfortunately, the MAS remission definition that was invented for the emapalumab trial includes a VAS of physician global assessment, which is based on a list of features, MAS feature, but it's obviously does not include lung disease. And when we discussed the retrospective application of physician global assessment, there were some concerns expressed by the regulators and the methodologists that this may not be appropriate. So the labs are certainly objective, and there's no way you can change that, okay? So we were trying to think, besides the MAS definition, in addition to the MAS remission definition that is used, what could we use? Now, the B-specific trial uses CRP and ferritin in NLRC4-induced disease. We are now thinking about this group of patients: Tiphanie arthritis, largely overlapping, mostly systemic, mostly IL-18 high, whatever they have regarding organ involvement, lung, liver, or only ultra-dotted, only relapsing MAS. And we have to come up with some objective measure. Now, the suggestion from the regulatory or there were suggestions? Maybe yes. The suggestions were very hard outcome, like length of stay in ICU stay, length of hospitalization. Were there any? Am I missing any?
Yeah, the exact words that I actually wrote it down. The exact words they were using, that we would need in a retrospective review clinically meaningful measures other than the laboratory tests.
Yeah.
As an example, they gave the days of hospitalization, ICU number of the days spent in ICU, need for ventilation, need for inotropic support, and those kind of things.
So that's exactly why I'm actually asking this question, because even if I don't necessarily agree with all their methodology, at least they're consistent in their answers, which is that my sense has been from real world experience in other trials in this domain, we have gotten beat up pretty badly about trying to use things like ferritin and CRPs as clinically relevant outcomes. The FDA sees them as surrogate markers, and what they see as clinically relevant outcomes are the things that you just mentioned, Alexei. And so I'm not opposed to collecting the lab data, but I say this as having had real world experience in this area. I don't think you can rely on those things as the kind of objective outcomes to use to get a registration for a drug. They want things like you just mentioned, Alexei. So I think we should spend some effort in thinking about how to collect those kinds of data, either retrospectively or prospectively, or how we're going to set up this natural history study, because that ultimately, I think, is what will make or break a successful registration.
There was one more thing that was a bit disturbing to me yesterday. We started talking a little bit about the geographic differences in the prevalence of the lung disease, and they immediately picked up on that, and they said, well, in this case, if there are geographic differences in the sort of phenotype of the disease, you also need to make sure that your patient population and your control group, your historic controls match in terms of geography as well.
You know, I had a thought about the criteria. Since many of these patients go in and out of MAS and kind of the subclinical MAS, wouldn't MAS remission criteria in a longer term by themselves be relevant?
So this would be time in MAS remission.
Yeah, it would be a time to reach that state. Yeah.
No, it's not time to reach. It's the time in.
Time in, because the problem is,
it's a long-term treatment. I think this is a great idea, Rashmi.
Mm-hmm.
You clearly, because your time in MAS, the point of MAS remission is that it includes the physician global assessment on a VAS. and the labs. But if we defined MAS remission retrospectively, I mean, as we were discussing earlier this morning, we could go back to the methodologist and ask the relevance or scientific soundness of retrospectively using a VAS. I mean, we all do it. We all define the disease of one of our patients 1 year ago more severe and less severe than the one he has now, for example, or he or she has now. So we can do that. But I don't know whether it's methodologically sound or not. We will need some clinical patients to help us in answering the question. But time in MAS remission, it's a very hard outcome.
Just one
This is
comment.
Bryce. Can I would add that some of the other things on the list there, Fabrizio, I think also are clinically meaningful measures, including glucocorticoid dose.
Yeah, we had a fight. We had a fight with the.
Yeah, no, I heard it, but in other studies, the glucocorticoid dose is clearly important.
Yeah, I was
No,
going
not
to
just the
challenge.
dose, but the exposure, total exposure, that would be critical, right? Sort of how quickly.
But I was going to challenge Nikolai on that because they approved tocilizumab in giant cell arteritis on a study that unfortunately was, I mean, there was, most of you may remind the design. The design is very good for us. It's a design in which you drive the patient in remission with glucocorticoids on a fixed dosing regimen and tocilizumab, and you start tapering glucocorticoids, you know, on a forced and defined tapering regimen until they flare. And actually, the primary outcome wants time to flare, which is clinically relevant again. But the second, you know, the secondary outcome was glucocorticoid dose. And it was pretty clear that the patients that were on tocilizumab required much less glucocorticoids to.
But Fabrizio, wasn't it the design of the trial of rilonacept that Norm Illowite was running? And it's, I don't remember what happened in that. All the patients were on corticosteroids.
I can't
to capture the.
Yes, they were all on steroids, and there was we had a consensus meeting to, you know, to try to figure out, you know, levels of tolerable labs that would allow you to continue to do a forced taper. So there's a paper written about that, and maybe that's one potential way around it. It's just very difficult to, you know, to have, especially, you know, historical controls where you have really detailed dosing information about steroids, because it just is not collected very well.
And, yeah, and the other thing I would add to that is that I think like that works great for a prospective study where you sort of have rules.
I know, Ed, you're right. I was using the argument to force the FDA to make the glucocorticoid dose a clinically relevant measure.
I mean, they
did not deny that. They just said it's not a primary measure. So that's what they were saying.
Does it make sense to include for retrospect, you know, historical, just basic vital signs? Like that tells you how the patient's doing. Like, are they still febrile? How many days till their fever resolves? How many days till they're no longer tachypnic? How many days till they're no longer tachycardic? Because they don't want to go home with any of those vital signs elevated. And that should be all collected.
You mean in the EHR?
What's that?
You mean just in the EHR?
Yeah.
At least while they're in the hospital, but.
That's what I'm talking about. Because we're comparing kids who are sick enough, right, that need these clinical trials. Those are very relevant things, right? Fever, tachycardia, tachypnea. You're not going to be enrolling kids who are feeling great. Those vitals are going to be off. And so if you want a comparator group, you compare other kids who have had episodes of MAS.
Right, exactly. We will be looking at those patients who are more likely to be admitted, sort of as a comparison group, right? Most of them would fail corticosteroids, so all these measures would be very, very relevant.
And I think as the comments in the chat are showing that those measures of fever and rash as well are very relevant to the families. It may make it's maybe more challenging to make that point to the FDA and other approval agencies, but it's clearly important to the families taking care of these kids.
It's harder to capture retrospectively in terms of, exact duration of fever and rash. I mean, and, we did collect home PROs for the Frost study where patients, reported their symptoms every other day. But that, is not something that's collected routinely.
No.
How many centers?
Our EMR is terrible, but it can easily track vital signs. I will give it that.
Yeah.
Right, but while they're in the hospital, when they go home, that's a different story.
Right, but this is sort of what we are looking for. Those will be the days in the hospital, I think.
Okay.
As a comparison for the trial, because again, all the patients so far that we have enrolled, for example, in the MAS trial, most of them were in fact in the ICU setting at the time of enrollment. So that's fine. But they will be in the hospital. And
How many centers collect like standard PRO tools on all for their patient nature of their visits? I mean, I know that we do, but that's because Pam Weiss cracks the whip on us, but I don't know if that's like a common practice or not.
Well, we do if the patient is enrolled in the CARA registry. That should be at all sites.
I mean, I guess so. That's I mean, I know you said it before, Yuki, but maybe that's actually a really good point. At least in U.S. centers, like it seems like getting people enrolled in the CARA registry is probably really important for this, because the kind of data that you want is actually what people will be forced to collect if they're enrolled in the CARA registry. I guess actually this brings up the other point though that we ran into with Grant's study recently, which is that some of these patients, if you don't meet either criteria, you can't get enrolled in the CARA registry, and so we may end up losing patients, right? So is there a way to fix that?
Well, yes, it is fixed. They can be enrolled if the physician, the registry doesn't require ILAR. It just requires that the physician diagnose the disease as being systemic JIA. So if that's the diagnosis, then the patient can be enrolled.
And if you're in the registry, then there's some, I don't know what the tool is you guys are using, but there's some PRO measurements that get taken at every visit then.
Yes.
Yeah, so it seems to me that that's actually hugely important. That may be like one very actionable thing that we could do to make sure we're collecting at least some standardized data that is patient oriented. The FDA loves PROs. That they like.
Yeah, but can't be prospective. Do we have enough PROs retrospective?
Yeah, no, you're right. Never mind. I'm sorry. I'm getting myself turned around here.
No, that's okay. It's important, but certainly we don't have Pamela with us.
Yes, but if we do have prospectively collected data, in the registry, so we should be able to use that data.
Yeah, but we would need.
That there may be patients that you wanted this data that weren't enrolled.
How many of these patients with predominantly systemic, this severe phenotype are in the registry?
Yeah, we have to do a deep dive and look for those.
Yeah, you have to do a deep dive, but I'm afraid there won't be enough.
But there's no reason why we couldn't start enrolling these patients now and have the data available, even contemporaneously. If we have the phenotype that we want to act as the controls, right? And that we should be able to find the patients and enroll them. And that way we have prospective data. Another thing that I see is the systemic JDAS. The systemic JDAS requires the actual temperature of the patient, as I recall, as one of the components.
Yes, you have to have a record of the temperature.
Right, that's another thing that's difficult to get retrospectively.
If it is in the patient charts and the patient was admitted.
Again, if the patient is admitted, we should be able to get all this data.
So
For
these patients, these severe patients undergoes several hospitalization per year. So vital signs and this idea and body temperature should be available during the
right. But when you're trying to measure, changes in disease activity through the JDAS, you're going to be capturing those patients when they are no longer in the hospital. So we have to make sure that we collect the temperature and vital signs when they're well as well, I think.
So let's assume we have a very efficacious treatment. Let's dream we have a very efficacious treatment for this group of patients. Yuki, those patients will be admitted in a state of relatively active disease, possibly controlled by a bunch of drugs, immunosuppressive and glucocorticoid drugs. Okay, they get enrolled into an open label trial, which we want to be extremely effective. So in a month, they should be, their disease should be down to 0. Essentially, they have no fever, no rash. I'm dreaming, eh? No fever, no rash. They're fine. They are home, and their therapy is significantly decreased. Their lab will be checked periodically in the subsequent 1 year of trial. I don't think can be anything. It can't be shorter than 1 year here. And they would have a CT scan repeated a couple of times per year, maybe at the end of the year, possibly. So a patient is an historical control would have had 3 to 5 hospitalization in that years. Can you comment, Alexei? Did you see many?
Again, we have this distinct clinical phenotype. So what phenotype we are referring to, right? If sort of looks like we are talking more and more about the patients with a lung disease. They do get admitted often, yeah.
So, and the patient with relapsing mass gets admitted often.
Yeah, I will add that things like JAK inhibitors, etc., have reduced the number of hospitalizations that you will see. And so the amount of steroids, etc., you can kind of keep on adjusting those. And I think that even in our group, I think in the beginning of a disease, a lot of patients get hospitalized a lot. As it becomes a little bit long-term, you keep on adding immunosuppressants, then it does reduce. And I think Ed's case study was kind of great to see, because I think this is why I was thinking it has to be a time-dependent measurement, because the key is that for 6 months, and I was talking to the parent yesterday, the 6 months, like the child has not had fever, headaches, all those typical things. So it is like MAS remission, except it's long-term.
Exactly. But Rashmi, what about the labs of the patient?
The labs.
No, I'm trying to say this is the patient that Ed was showing. Okay, that was going great. I'm sure his lab are great, and he will probably, I don't know, Ed can comment on that, but probably the labs of the patient would fit the MAS remission. But the labs of a patient on a JAK inhibitor that is maintained going up and down on glucocorticoids and possibly on canakinumab or something else, would the lab always fit the criteria of MAS remission? Even if
not always. For periods of my understanding is that for periods of time, yes, but they always fall out of it. Then they.
That's exactly what I meant. Yeah. Even if the patient is not hospitalized, your idea of time in remission, it's great. And these patients are being tested often, lab-wise.
Yeah, I think Randy has a point, yeah.
So again, I think time in mass remission, I can't.
All of what we're talking about now is, I think, predicated on the fact that most people are convinced that the only kind of trial we're going to be able to do prospectively is to compare it to a retrospective cohort. And I still think we should collect the data on the retrospective cohort, but I still think there are options of how to do clinical trials to get around that are going to be more amenable to the FDA. Whether that's comparing one drug to another, where we don't know what's going to be better if they haven't already been on it, or whether we do some kind of placebo trial that's weighted for getting the drug, however you want to weight it, with a very short time frame of a measurable response. And I don't know what that will be, but I think we're smart enough as a group to potentially find a measurable response in a short period of time where they can cross over. So I wouldn't completely give up on doing a prospective trial for this group of IL-18 dominant patients, without having to just do observational study to see how they do and compare them to retrospective cohorts.
But you're not referring to MAS, Randy, right? You're not referring to...
No. It's referring to the chronic patients.
Mhm.
No, I see your point, Randy. The issue with my experience with the regulatory has been the length of the placebo period and your outcome, your escape rules to escape to active drug. And the points here are that they will not accept a laboratory measure of a laboratory criteria to escape to. Exactly why they don't accept a laboratory measure that they call surrogate as a primary outcome, to Ed's point. And the second issue is the time in a chronic disease. So I remember discussion in which 2 weeks was considered not sufficient. 6 weeks was okay. But that has nothing to do with the chronic lung disease.
The other thing that we need to remember is that, is it going to be acceptable to the patients and parents? And based on the discussion yesterday, I doubt it.
I mean, that is if you're okay crossing over, whether it's a placebo or another drug like a JAK inhibitor, with weighted towards the thing that you think may be better, but there is equipoise because there's no data to tell you that any of these are any better than anything else.
So I think to the point of acceptability to patients and parents, I mean, there's a reason why CARA and PRSCG have moved to withdrawal study designs, because I mean that's really the only way to do it, right? I mean, everybody has to get drug up front, and you have to do a randomized withdrawal. So I think that also brings with it a set of complications, in terms of how you interpret the data, how you do your trial design. And I share with Fabrizio a lot of the struggles that he's described. I mean, it's not so easy, Randy, to pull these off. So I appreciate why the group is trying to think about, getting a control group in this way, because it would facilitate, I think, a trial if we can pull it off. Can I ask maybe a methodological question? I don't know if this helps me think about this or not, but are we thinking that the idea is that if we get a natural history cohort, we would have a reference range for what no treatment would look like, and then we would just do a treatment arm and do a comparison? Or would the idea be to somehow collect a lot of data on individual patients and do some kind of, almost like a propensity mapping kind of methodology, right? Where you have, this patient looks like this patient in our study, so we're going to match that control to that patient. Because that might also change what kind of data you want to collect.
These are not mutually exclusive hypotheses. To me, this registry has to be wide in inclusion, and then we should select based on a propensity score. It was mentioned yesterday. It's too bad you were not here yesterday. But it was mentioned yesterday, and I guess the people advised us that this could be a reasonable approach.
Yeah, it should be a broader registry, but then we should be able to apply certain criteria to select a certain population of patients from the registry that would match the population in a specific trial. That was the idea.
So I think we should be broad and in inclusion, and yes, I think we should try to match. And the propensity score looks to me, I'm not a statistician, the best way to do it. It appears to me. Rashmi, I think the more I think about it, I think time in remission is great, because this is something that is very important in the relapsing smoldering patients, and these are being tested lab a lot of time. We should run some quick simulations on some of our patients. I guess the larger centers who have these patients should just look at that and see what this is all about, with or without effective treatment. And remember, time in HLH response was one of the most important secondary outcome. I think was the first secondary outcome in the HLH trial that led to the approval of emapalvir in primary HLH in the US.
I would like to bring up one more point that the FDA mentioned yesterday, right? Remember they were saying, well, the time goes on, we keep introducing new treatments, and we need to make sure that historic control is not coming from a different era, if you wish. So if you think about what sort of has happened since. Well, first of all, I think the first probably important time point would be the introduction of IL-1 and IL-6 inhibiting agents. And I would say probably that should be the year 2010, although probably for anakinra, it would be 2005. So we should not go further than that. And then sort of the more recent development, and Rashmi mentioned it several times today, is the introduction of JAK inhibitors. And I believe that again, Rashmi, correct me if I'm wrong, more and more patients now are on JAK inhibitors, correct?
Yeah. I think a lot.
So my point is that we need to consider that as well when we include patients in that retrospective registry, right? So how far do we go? Certainly not further than 2012, but how much are we worried about the JAK inhibitors changing the landscape a little bit?
In some sense, you could say that you'll actually get better controls before the JAK inhibitors, because right now what we are doing is that we are putting in a lot of immunosuppressants to actually keep some measure of control, and maybe data will show that. I actually wanted to take this opportunity to ask the parents, because I think Vincent made a very good point in the chat, that I think just to get a parent's perspective, and if one of the experts can describe these two types of trials. One is where you get where he is talking about, Vincent's talking about short placebo controls for fast-acting meds are more acceptable to me than withdrawal. Can someone just explain in 2 lines what those 2 options are, and just ask the parents what they think? To post it in the chat.
Maybe I'll jump in because I'm in the middle of running a randomized withdrawal trial right now. So tradition in a sort of classical placebo, sorry, which camera am I using? In a classical placebo study, there are 2 arms. You get drug or you get placebo, right? And then you start asking how you're doing. And you don't know if the drug is working or not, right? So you could be on drug and it's not working and you're not getting better, or you could be on placebo and it's not working and you're not getting better. And so you wait and you see what happens, and you're loath to unblind because you need to collect the data. In a randomized withdrawal design, everybody sees drug up front. If you consent to it, you're getting drug, boom. And then you get drug for whatever the lead-in period time is, 6 weeks, 18 weeks, whatever it is. And then you hit the second phase, which is withdrawal. And you either withdraw to drug, in other words, nothing changes, or you withdraw to placebo. And then what you're looking for is a flare. And there's a change, right? Presumably everybody's going to get into the withdrawal phase, you must have gone into a remission. And so now as soon as you see a flare, you know something has changed, you unblind, and if you flared and got placebo, you immediately go back to drug. So in many ways, the idea of a randomized withdrawal trial is to actually limit the amount of time that you may actually end up being on a placebo. And I think that works well for cases where the stakes are high, like lung disease and like we're talking about. So that's why people often choose this design as opposed to the traditional placebo-controlled trial, where no one wants to end up on placebo and sit in that arm for weeks or months.
So Ed, this is Vincent. So I just don't agree. My son was very, very sick at onset. He doesn't have didn't have all these complications and was not a refractory, thank God. But when he was really sick like that, if I gave him a drug and it was working, to think that I would be pulling the rug out from under him, I just wouldn't do it, right? Even I would rather, and I did enroll him in the rapport study where it was randomized placebo versus drug. And then after the placebo period, you definitely got drug. It was open label. And when I enrolled him in that, my thought process going in was, well, I know this is a fast-acting drug. So if it doesn't work, if I don't see improvement within 2 days, I'm just going to drop out, right? And I'll go I'll ask for anakinra or something like that, right? Or, like I'd rather wait a couple of days in the beginning than have something pulled out from under me because of how sick they are when you're going through it. It's cruel to take it away, in my opinion, in this condition. Maybe a poly or an oligo or something like that might be different, but that's the way that I feel about it.
There is one more issue here. I've spent quite a bit of time looking at the lung biopsies from these kids, and what strikes me is the degree of alveolar remodeling. And that is certainly going to be irreversible. And my feeling with each flare of at least the lung disease, I think there is increase in the degree of that alveolar remodeling that is going to be irreversible. So with each flare, we have an additional irreversible change that I think we should try to avoid at any cost.
So I'm interested. Thanks, Alexei. And I share that same opinion, which is why I think we're talking about these designs. I'd love to hear from other parents because, I've gotten exactly the opposite perspective as well, where parents have said, I am absolutely not willing to put my kid on a placebo. I want to know my kid is absolutely getting drug up front, which is why these other trial designs have been considered. And I guess the only other thing that I would just say is, I think we should set some expectations up front, and I'm not in the business of being cruel to kids at all. I hope that is not the message that's getting out there. When you participate in a trial, it's a little, I would say it's a little dicey to try to use it as just a way to get treatment. If your intention up front is to immediately drop out of a trial if you don't get the arm you want, then it will never be possible for us to conduct real trials. So I think what we need to do is find a trial design that is acceptable to the most number of folks that would allow them to feel comfortable staying in whatever arm they end up in, no matter what. Otherwise, if everyone decides that they drop out after 3 days, if they don't like the result, then the trial never completes and we can never get a result. So we need to find designs that are acceptable. And maybe the answer is that we just have to use a historical control. But you can see that we're struggling a little bit with that design as well.
Why don't parents speak up? I mean, you've been explained 2 trial designs. One is the withdrawal one. The second is the placebo one. If you had to participate in a trial and if there was a drug you were interested in and your doctor said this might be relevant, which one would you be more willing to do given your situation? And
can I just add one more thing, Rashmi, real quick, with the placebo design on a fast-acting drug? Like, let's take like IL-1, for example. Again, the placebo period for an IL-1 study should be like 2 days or 3 days. Within 3 days.
This is not acceptable to the FDA, Vincent.
Yeah,
it can't be done.
But it should be, because we know. You
have to be realistic, Vincent. It can't be.
Yeah.
Should be, yes, but it's not. Placebo period in tocilizumab study was 12 weeks. Canakinumab was a withdrawal design, which that's it.
Okay, parents, speak up.
I guess the other question though is how long does what is the period of time that we expect either to find hard evidence of the drug working, and also when it stops working. If you're going to do a withdrawal study, which I don't agree with in the situation either, But if you did a withdrawal study, I mean, what are the outcomes and when do you expect to see a change in them?
Exactly, Yuki. I think this is the point in the situations we are discussing. When do you expect to see a change, a measurable change that can be used as an objective measure of efficacy, and then as an objective measure of loss of response in the withdrawal part. In the placebo part, in the placebo standard placebo design, it's the same issue. How long is gonna take before we see a response that is measurable and significantly different between the placebo-treated and the active drug-treated subjects? And the longer the period to see a response, the longer a period needed for the placebo patients to stay on placebo. Brutally said, not to show a response and not to have a response. So the situation that Vincent was outlining to you of a fast-acting drug is the ideal one. You can have an objective measure of the efficacy, okay? Fever is disappearing, that's fine, easy, okay? But can't be CRP because none of the regulator will buy CRP as a measure, okay? Now, in a feverish patient, this is relatively easy and it's short term. However, in a severe situation like lung disease or relapsing MAS, I see these both designs as very challenging, I would say, in general. Then I have a methodological problem with the withdrawal design. You do your trials in the responders, and it doesn't provide data that are usable in real life. But this is methodology. It has nothing to do with your kids, okay? But you remember, you're doing the trial in the responders because you open label, you treat open label, then you select the responder and you randomize those to withdrawing the drug or to continue the active drug. So essentially, you're taking out the non-responders, which I think.
Having said that, though, the FDA does.
The FDA is wrong.
Methodology.
And even they are wrong occasionally. The FDA is totally wrong.
But I'm just a matter of pragmatism. It is a way of getting registration for a drug.
I know, but there's a bias. The data may not be reflective of what happens in real life because there are trials in which 35% of the patients did not respond. ACR 30. Okay, and if you sum up the non-responder and the one on active drug in the withdrawals period, okay, you end up with rate of non-responder, which is far too high. Anyway, Luciana, I'll shut up. Maybe for 5 minutes.
Okay, Fabrizio, no, it was a really interesting point. No, just my point as a parent, a perspective as a parent is this. I feel more comfortable with the withdrawal perspective, depending on the washout period and whatever. But if the doctor is suggesting and telling me that this might work, go on this trial, I would. I don't feel comfortable at all being a mom with MIS kid going to a placebo trial. So just this that I wanted to.
One way or the other. One way or the other. Placebo.
I would feel comfortable like with withdrawal if like, okay, you have a promising drug, sounds better to me than the placebo one. Well, if you have the option that we talked before, like, okay, you go placebo and then you can get like the drug 3 or 4 months after, then this might be an option as we discussed it. But if this is not viable, then I would go with withdrawal.
Can I jump in and add something to that as well? I think Vincent's point is very true in terms of the kids that are very sick at onset. But I'm sitting here thinking through it and struggling that a lot of our kids that are refractory, I mean, we're trialing these drugs in a way on our own. We're burning through medications. We're going on a medicine knowing that it may last our kid only months before we have to make a change again. And so in a way, the withdrawal process makes more sense to me because if my child was to start a medication, for instance, if he started a new biologic, there's a chance that he's going to have to come off of that in a few months anyways, or it's not going to continue working. I mean, we switch medications usually every year to 2 years. And so I feel like for a lot of refractory patients, that's become course for us. And so I'm not saying that's a good thing, but I don't think it would be as jarring, if that makes sense, to be on a drug and know there's a possibility that at some point it's not going to work. They're going to get a placebo or get withdrawn off of it, because we've lived that for many years just with other medications that are currently available. That's very different than onset, where if I was told that my child could take anakinra and maybe be well and running in 48 hours, I think my feelings would be very different about it at that point versus now 9 or 10 years into stacking medicines and burning through lots of medications.
But being on a placebo to start with doesn't mean you never get drug. You may start on placebo, you may get randomized to placebo, but after a period of time, you're also going to be able to get drug. So I don't know if that makes a difference, doing it that way. And the response may be clearer because, the response in the withdrawal trial is seeing how long it takes you to flare after you've gotten the drug.
Yeah.
And it's a lot clearer that, if somebody responds to medication versus not getting medication, it's a lot clearer, what the response is actually.
I actually think I kind of agree with that. I mean, I think from my perspective, right now we are under the care of a doctor who's trying to keep things under as much control as possible. We have some degree of control with a bunch of options. And I think many patients in the group are in this situation. It's not a good long-term thing, but they have some control. And I think that if you have a chance for a better option, a drug which is more targeted, then you wait 3 months. And then you have a chance that maybe you're not in the, you're in the placebo group. That means nothing changes. You stay on things the way they are. And then 3 months later, you have an option at a better drug, more targeted drug. But in the withdrawal, what I would really worry about is that you have achieved some measure of control. You go on a different drug, which maybe works better, and then you take it away, and then you go right into MAS. That would be my big worry, is that the withdrawal design has a lot of risks for MAS-prone kids. Because you've lost control
to
from
make
the
it even
process.
worse, this additional flare may bring some irreversible damage. That's my point.
To the lung.
To the lungs, yes.
Although the same could be said for a placebo-controlled trial, right? The time that you're on placebo and accumulating damage in the placebo phase, you've got the same problem, Alexei. So to your point, Alexei, if that's really what our worry is, then we should scrap both of these prospective designs, and focus on this natural history idea. Although that is also a high risk choice, because I have this concern that you do all that work and the FDA will still say no dice, right?
Yeah.
So because it's a very non-traditional approach. Whereas we know that the FDA accepts placebo-controlled trials, and we know that the FDA accepts withdrawal designed trials.
But I think this discussion has showed that both of them are flawed, right? And we talk about this a lot over the last however many years. So we definitely need another solution that's more that is based in science, right? So that the FDA is going to approve it. Somebody's going to have to take that risk and design that study and do it in order to move the field forward. Because again, based on this conversation, neither one is acceptable. So we have to find something that is acceptable, but also going to be able to answer the question.
Yeah. I
mean-
actually think after this conversation that we should actually think about this. Like the question is, what is the sample size needed? If we need 10 patients, then maybe I think parents also understand the need for medications. And what the FDA said yesterday was not promising in terms of your non-traditional trial design. It was really not promising. It was blunt, it was direct, it was depressing that there might be a drug, but it's going to be very hard to get it. So I think that we should, as a parent group, we should talk within ourselves, understand these designs, understand these options. Veronica Miller had mentioned something about a concurrent observational cohort. I don't know exactly how that works. Think about that as well. And, probably follow up with a meeting with parents and doctors. We'll set that up. The foundation will set that up in 15 days and follow up after the patient group has educated itself better about trial designs and give a more informed opinion. Otherwise, I don't know whether we can actually do the MAS. It seemed like external controls can work. For this, it seems very difficult.
I mean, I would just to back up what Ed's been trying to say, if you do a randomized withdrawal and you're worried that your child's going to flare their MAS, which they likely will do if the drug is helping them, let's say an IL-18 blocker or whatever you choose, then if your criteria for flare are mild, then you go right back on. And at the same time, you learn that it took 1 day or 2 days or a week to flare, whereas the patients who stayed on med that was working, they didn't flare. So of course it's your child, and of course you don't want to take a med away that's working, but it's not like you're permanently removing it from it. And if it worked for them in the first place, it's likely going to work for them if they meet whatever low bar you may set for what a flare is. The other point I will make that avoids both concerns is a comparator trial, which I'm the only one I think has been pushing that, and yet I haven't heard anything about why we shouldn't do that, because we don't know what the right drug is. So, and I'm not saying what the right drugs are to compare, and you could even do 2 to 1 if you think for whatever reason the IL-18 blocker is going to be better than a Janus kinase inhibitor for someone who's not seen it yet. And like people have said, people have already kind of started trialing these on their own just out of necessity. But we don't know what's the best, whether it's emapalumab or a JAK inhibitor or IL-18. And so at least you're going on one of those. And if you build in a crossover design, then you can cross into the other one if you think one of them may be better than the other, or, either way, at least you're getting tried on potentially 2 different drugs if one of them doesn't work.
Well, Randy, the FDA was very clear yesterday. With that scenario, we would still need some kind of a control. And again, it boils down to this historic control.
But there are two different kind of studies that we can think of, Rashmi. And I'm thinking what you were saying before, and to follow up on Randy's proposal. There are investigator-initiated studies in which you can certainly look at multiple drugs. They have to be approved. Again, I don't know whether we can use off-label to do that. It's a different thing. We can do sequential, we can do smart design, we can do Bayesian, as Bas was saying, adaptive, that's fine. The point is that we already know that most of the drugs that are available they are not effective, okay? We know that the JAKs appears to be effective in some patients, or at least they allow better controls. The new drug, okay, coming are property of a company. And from what the FDA stated yesterday, what if you use 2 arms to compare 2 drugs and they work the same? None of them will get approved. And we don't do a good job to our patients because we don't get the drug approved. So I think we should distinguish these 2 scenarios. I think it's great to try, you have been doing N of 1 trials in your patients. I'm sorry. I think Hermine said it very loudly yesterday. It was great. N of 1 trial in your patient. And you compare it before the new drug and after the new drug. And this is fine. And we can try to do better than that, you know, and for the patients that are not in trials, that's great. That's an approach. And Cara is very good in this with treatment plans, okay? On the other hand, we need registration trials. Otherwise, the new drugs will not be approved. And this, you know, I don't think placebo is acceptable there. Even if I'm not a parent of a patient, I don't think placebo is acceptable, one way or the other.
I mean, placebo versus the chance of not getting an option was of a more promising drug. I mean, you have to compare, I think from a parent perspective, you have to compare it with that. You saw the session about bone marrow transplant, and you saw how patients with SJI-ALD who are not coming under control, that's what's the future is. So from a parent perspective, that's what you are thinking about, which is why I'm very surprised that, you know, I'm surprised at myself and I'm surprised at the other parents that we are at least considering the two designs and trying to think what we could live with. Because, you know, and Carrie, I see you about the natural history, just speak, like, you know, you can, but, you know, it was, when they go to the FDA, it won't be us, it'll be the company and some of you in the room. So I think if they are upfront telling us that, I think with MAS, natural history might work, but it sounded like we can identify a way to do it. And we should try for refractory SJIA. It's really important to do it, but it really did not sound like there's fundamental issues with that trial. So we should not put 2 years of work into something, planning a trial, which is ultimately not going to work. Fabrizio, you're muted.
Yeah, I know, but we should plan a natural history study.
Yeah, that we should do anyway. That I think is
anyway.
A great idea.
If a company ever decide to go with a new drug,
yeah,
the resource of the natural history study will be invaluable to the community.
Agreed. And
I wouldn't be pessimistic on this. I would rather be optimistic.
Well, I'm optimistic about the natural history study, but not necessarily to help. We'll see. We'll plan that. Okay, I think we need to wrap up this session, and we can continue this in the last working session and come up with real action items for next step. But before we do that, we want to come back to that that poll that we had planned that we will put up. Candace is, you know, waiting to put that up. And as far as reminder, or not reminder, for sharing with people who've not been here so far, who weren't here in the morning, for those who've been attending the conference and we've seen all the discussions, we want you to, you know, participate in this poll. I don't see an option to actually vote, Candace.
Yes, I'm launching the poll now.
You're launching, yeah. So the first one will be just for the doctors, for the physicians, and then everybody else will vote. So we want to just have a record of the discussions and what we.
Was there only one question? Only one question flashed up on my screen.
No, I think that we had the two questions. I think I copied, pasted while we were in the session.
This is the old one.
Yeah, this is the old one. This is my mistake. I apologize. No, I think Candace, I think you launched the old one. Let me just send this to you, the one.
Okay, sure.
Okay, this is the sentence we finally decided on. Let me just paste it here. This was the sentence, yeah. I think people started voting. I think we're about maybe done with the doctors one. I don't see more new votes coming in. Is everybody yeah. Okay. Should we do the next one? Is everybody done voting, all the doctors?
Yes.
Okay, just give a few more seconds and then I will launch the
Okay, we'll give a few more seconds and then we'll. It won't close now. Okay, for everyone. I think that's it, if I'm not wrong. Okay.
Rashmi, I don't have a link for the next session. I just checked my calendar. Any chance you could resend?
Yeah, we'll get that and we'll send that. Okay, so I think it sounds like it was 92% for the doctors, yes, and 97% for everybody else, which is mostly parents and patients. So we'll have these on the record for the meeting. Okay, everybody has the next link, so then we can log off and we'll be back soon.